Thank you for having me along here, particularly to Professor Chu. It's a delighted to be a guest. I wish I was there in person, and hopefully sooner rather than later we'll return to travelling. As you mentioned, I've been asked to talk about application for spacing devices for prostate cancer treatment. Most of you would know Melbourne, a city of around 5 million people, where I'm coming from today, and we'll hopefully have you back to Australia next year with the UAA conference. I just wanted to briefly go over some publications that I've been involved with spacing devices. Way back in 2014, we started writing about fiducial markers, which we use regularly for external beam radiation, but also spacing devices in radiotherapy. And subsequent to that, we've published in the BJUI, World Journal of Urology, and Brachytherapy Journal on the value of these devices with my colleague, particularly Michael Chow. This has been a real journey for us, and certainly hope to share you some of that in my short talk today. For those of you who would like to read up on the current status of hydrogel spacing devices, there's an excellent article, which is a systematic review in JAMA Network Open, and that was published just last year. And that really is a great article to read to catch up on all the data and the value, I believe, in the spacing devices. And you can see here from the conclusion that for men receiving prostate radiotherapy, injection of hydrogel was safe, provided prostate rectum separation sufficient to reduce rectal radiation, and was associated with fewer rectal toxic side effects and higher bowel-related quality of life in late follow-up. So I think there certainly is value in these spacing devices. So we often call these the shields for patients. They understand the concept of a shield and what a shield is trying to do. And obviously we're trying to get the hydrogel between the rectum and the prostate, as is indicated here. And this is a perfectly positioned hydrogel application. Originally, these devices stem to us from cosmetic surgery where hyaluronic acid was used, but pretty quickly we've moved to hydrogels. The reason is they are cheaper to manufacture, they have a low allergy profile, and they seem to have better distribution in the perirectal space. They also degrade quicker than hyaluronic acid, and they will be stable for a 2-month course of external beam radiation and, of course, for brachytherapy, but they will be dissolved by 6 months and excreted renally, giving them an advantage of not being a permanent device. Currently, and probably where you are in Hong Kong, we've been using them pre-external beam radiation, also pre-brachytherapy, both low-dose and high-dose rate brachytherapy. Some clinicians have started using it pre-post salvage radiation, and we've also used it in some special circumstances for stereotactic ablative radiation where we're salvaging nodal disease. And I can show you an example of that here, whereby we can see a PSMA PET scan, which we use a lot of in Australia. And you can see here with the spacing device, we can move that node away. And this was the only site of disease in a patient who post radical prostatectomy who was able to have SABR. So I think the spacing device has evolved from just being used purely in the primary setting to salvage and also special circumstances. Generally, it requires a 15-minute general anesthesia. It's a minimally invasive procedure. Patients are home the same day. And in general, we use same equipment we use for brachytherapy to inject. You can, however, do it freehand. I just heard you talking before about freehand biopsy and grids, and traditionally we use the same setup with our transperineal probe. We do use stepping devices, although I must admit I find for inserting the gel, I often remove the grid if there isn't an easy access to where I want to be, and also I can angle the spacing device a little better. So the grid has advantages for putting in fiducial markers, but it can easily be done freehand, and I don't believe the grid is absolutely necessary. We can see here a graphic of what we're trying to achieve. Obviously, we have the rectum, the prostate and the bladder and the seminal vesicles. And you can see here we're trying to place just in that key plane, initially hydrodissecting if you're using space OR, and then placing the gel to move the seminal vesicles and prostate away. Many of you may be familiar with the Boston Scientific Space OR kit. It comes with a hydrogel, as I said, used by plastic surgeons. It's a new use for an old device and dissolves over 6 months. You'll see it comes all pre-packaged. And then here we have the different components, including the needle, and I'll focus on the Y connector in particular. I won't spend too much time talking about how to set up the devices in terms of mixing up the components, but I will try and give you some tips and tricks that I've learned over the years. The first one is when we go to hydrodissect to place the saline, which is the first step in entering the spacing device, it's important that we go in, obviously, under ultrasound guidance in the plane between the prostate and the rectum, just beneath Denon-Villiers fascia. And I think it's very important that you have the bevel facing downwards, and that seems to have an advantage to pushing away the perirectal tissue. And I think that's my first important tip for this type of procedure. Secondly, when the gel, as you know, is prepared in two different colors, the blue and the clear, and is mixed up usually by the operating theatre nurse, it comes together, and obviously you need the two components to join for it to expand and for the polymer to link. Now, it's crucial when this is being undertaken that it's prepared appropriately. There are nice videos on YouTube how to do this. There are very good instructions with the device. It's important that both agents are not, however, mixed in this Y connector device too much prematurely, because it will obviously, just like super glue, set, and that can be an issue when you're starting out. And that's important. I'll come to the next point specifically, which is to inject out all of the air, except leaving a small component just below the Y. And the reason we do that is to prevent this premature mixing, because the minute you have these two components in the Y, they will set, and you'll have to replace the Y device before injecting. So it's important to leave a little bit of air between the two. Now, my next point is that when you inject, you should always inject with the needle and syringe upwards. The reason we do that is because of the air bubbles which have been left here. When we inject, we want the air bubbles to float to the top of these two syringes, so that we're only mixing liquid and liquid when we come to actually inject. Because if you recall, the procedure first is to put in the hydrodissection, remove the saline, which we use to hydrodissect, and then replace that with this Y connecting device, and then inject. So it's important to turn the wrist upwards to allow any small air bubbles to be left in the top of the syringe area. Finally, once you decide that you're in the correct place from the hydrodissection and you've reconnected the Y connector here, it's important that you do one continuous injection. Now, that's important because when you stop, again, the gel will form and can block up the Y connector. So I think from another tip is to continuously inject and be happy that you're in the right space. I will, however, stress that it's important that you do not have to use all of the components in each patient. Some people have larger prostates. Some people have a narrower anterior to posterior range. So it's not absolutely necessary to use all of the product, and it may be counterproductive in some situations to do that. I think also it can open up issues with the rare complication of rectal mucosal ischemia and so on if too much is put into too small an area. So you only really need to put in, I think, most cases, probably 2/3. In larger glands, the whole of the gel. Here we can see here, this is a patient where I placed the gel undergoing moderate hypofractionation, external beam radiation. You can see here his bladder with a prior TURP defect, and here I've used about 2/3 of the gel between the rectum and the prostate, and it's sitting there nicely and easily visible on the MRI, doing its job as the shield that we expect. I think complications, fortunately, are very rare with these sort of devices, provided you follow the tips that I've just mentioned. As I said, use of too much gel or too little gel can lead to a lack of sculpting. Too much gel, as I said, is counterproductive. However, too little gel or put to one side can also be a problem. So you do need to have good quality control when you first start out, making sure that you're spreading the gel evenly between the left and right sides from the apex down. I think, fortunately, perforation of the rectal mucosa is very rare. However, I will show you one case in a post-prostatectomy patient, which I'm aware of. And finally, very rarely, obstructive lower urinary tract symptoms can occur where there is a very posterior urethra. So where you have a very posterior urethra, just be careful, again, not to use too much gel, because that can push the prostate into the urethra and cause some lower urinary tract symptoms. I mentioned the spacing device here. This is a patient post-radical prostatectomy that unfortunately a colleague injected the spacing agent here. You can see fiducial markers, but here the spacing device, there's air which has escaped into this cavity through the rectum because the spacing device eroded through the rectal mucosa. Now, fortunately, there were no long-term consequences. This was dealt with a flexible sigmoidoscopy by a colorectal colleague and simply left alone, and it healed. And in most instances where there is a perforation, that's all that is required. However, it will obviously delay radiation in most instances. And again, I counsel you to be very proficient early on at getting the correct space. I think using the gel for post-radical prostatectomy patients is a fairly advanced technique and one that I would only use when you're very comfortable using it for other situations. There is obviously, I've talked mainly today about the Space OR gel, which is the one which I've been most familiar with using, but I've also used another competitor called Barry Gel. I will just point out for you some of the issues between the two. I think the mixing can be moderately difficult, but easy to learn for operating theatres doing this all the time. There are good instructions, and I think once mastered, it's not a problem. I guess with the Barry Gel, it's fairly easy as there's really no mixing required. I think it is possible to get blocked injection ports if you mix too early or don't do a continuous injection, whereas that's quite rare with Barry Gel. I think you do need to use hydrodissection, obviously, with the Space OR device, which I believe can be an advantage because you can be certain that you're in the right place, whereas Barry Gel, some would say that's a disadvantage because you don't need to hydrodissect, but you have to be very confident that you're in the correct space. Again, that's an experience issue. I guess we mentioned one continuous injection for spacing device, Space OR, whereas with Barry Gel, you can actually sculpt a little bit more. In other words, you can inject without being continuous and bulk up one area if you had to adjust, and that can be considered an advantage. Ultrasound interference can happen with the Space OR device, not so much with the Barry Gel, and some people perceive that to be in real time an issue. I don't think it's a particular concern, but it certainly could be. Finally, if we look at data, there's a lot of data on the Hydrogel Space OR device. I've already showed you some publications, whereas there's fairly minimal data on Barry Gel, but I expect that to change in time. But I think overall, there are certainly some advantages of the Space OR device versus some advantages of the Barry Gel. And I guess you just have to be comfortable, I believe, with one of these devices and become proficient at it. And then I think that's where you'll get advantages for your patients having radiation. That was pretty well all I would like to say. I only had 15 minutes, but I'm happy to take questions. I just wanted to reiterate that the UAA meeting is in Sydney in October next year. I'm on the organising committee. It's been chaired by Shomik Sengupta. We plan to have an excellent program there, and we look forward to having our friends from Hong Kong and other parts of Asia coming to join us for the UAA in 2022. Chairman and organising committee, thank you for the opportunity to share these thoughts today. And as I said, I'm happy to take any questions related. Thank you very much.